Hi, my name is Sari Siegel, and I'm the founding director of the Center for Medicine, Holocaust, and Genocide Studies at Cedars-Sinai Medical Center in Los Angeles. It is a great pleasure to be here today to tell you a bit about my research, and hopefully on the other side of this, you will really agree that this is a fascinating subject and something really worth discussing. So let's begin. I'll start out with a definition. Prisoner physicians were camp inmates who, on account of their medical training, were recruited by numerous parties, including camp administrators, private companies, public businesses, and local governments, to utilize their medical knowledge and skill sets towards a variety of ends in the prisoners' hospitals and outpatient clinics of Nazi camps. Despite the heightened risk of contracting illnesses from their patients, the doctors' work in such facilities gave them advantages compared to the average camp inmate. The chief reason is that they worked indoors, whereas so many other inmates were assigned to outdoor labor details, which left them vulnerable to the elements and conditions like frostbite. Another advantage was the relative lack of violence within these facilities, because typically there weren't prisoner functionaries beating inmates for perceived infractions. Plus, they often did not have to go outside for roll calls, which required standing outside at attention regardless of the weather for hours at a time. Also critical was their access to extra food, from larger rations, the food left over from people who had no appetite, or both. It is also important to note that they held another major advantage over the average inmate. They possessed useful knowledge that could not be conveyed easily. In other words, they were harder to replace. Their lives were of greater value to camp authorities and other parties, making them less likely to suffer from arbitrary violence and murder. Until recently, historians have spent minimal time studying this group. I believe there's a reason for these figures' obscurity, especially when it comes to Jewish doctors who were targeted for murder within the Holocaust. Preeminent Holocaust historian Raoul Hilberg sums up the matter effectively. Quote, "The sheer passage of time governs the slow disintegration of inhibitions that have blocked questions and answers with respect to the behavior of victims in extreme situations." Unquote. In other words, for a really long time, the matter has been almost taboo. But now, with the passage of time, scholars are more willing to explore the behavior of prisoner physicians and other prisoner functionaries like block elders and labor squad directors. The distance makes it easier to reveal that these victims of Nazi persecution and attempted annihilation did not always behave in ways that people, especially people who were not there, would judge. Survivor and author Primo Levi called these figures prisoner functionaries and assigned them to a conceptual realm called the gray zone, where the two camps of masters and servants both diverge and converge. To put it another way, the gray zone is a realm of moral ambiguity because its occupants, including capos and block elders, were themselves victims of the Nazi regime, being concentration camp inmates in the first place. At the same time, however, prisoner functionaries assigned tasks benefited the Nazi administration of the camp and were often detrimental to their fellow inmates. Given prisoner physicians' roles in camps, something we will explore shortly, they too were prisoner functionaries and so-called privileged inmates who occupied the gray zone. Their dilemmas inherently carried another level of complexity, though, that of medical ethics and the expectation that they do no harm. Unlike any other group in the camps, they were presumably beholden to a professional code of conduct, the Hippocratic Oath. Therefore, any suspected betrayal of this code often struck their fellow inmates as an insult more severe than what they witnessed from other prisoner functionaries. I want to establish right now, just get it out there, my position is not one of judgment. As Primo Levi writes in his Gray Zone essay, it is necessary to declare the imprudence of issuing hasty moral judgment on such human cases. Certainly, the greatest responsibility lies with the system, the very structure of the totalitarian state. So in my mind, our goal should be understanding, to the extent that it is even possible. I want to explore what the Jewish prisoner physicians did, what their circumstances were, how they navigated those circumstances. How did doctors behave when they found themselves in the extreme and unprecedented context of Nazi camps? How should we think about this conduct? Many people are tempted to label prisoner functionaries' conduct as collaboration. However, I consider this to be a flawed approach. After all, the term is weighed down with substantial negative connotations. Furthermore, collaboration implies that an inmate made a conscious decision to further Nazi goals. The idea of choice is particularly troublesome in the context of Nazi camps, as the gross power imbalance between Jewish inmates and the Nazi guards and administrators greatly limited, and perhaps even eliminated, the prisoner's ability to pursue a desired course of action, especially in the face of likely consequences. I also see flaws in the use of the term cooperation, because the prefix co communicates that two entities of equal or similar stature operate together. I prefer to frame Jewish prisoner physicians' conduct differently. I think of their behavior as the product of coercion, as this term immediately communicates the existence of a power imbalance. It is behavior that emerges from the use of bodily harm or the threat thereof to compel someone to perform acts counter to one's desire. Central to my thinking is the doctor's room for maneuver, the extent of an inmate's ability to choose one course of action over another. It is also crucial to recognize that this room for maneuver was not static. It was constantly shifting in response to ever-changing circumstances in the doctor's midst. It is hardly surprising, then, that Jewish prisoner physicians' behavior shifted as they reacted to their dynamic environment. And one important course of action could be resistance to the Nazis. So, how did I first come to think of this dynamic framework, which I termed the coercion-resistant spectrum, to reflect the spectrum of behavior that prisoner physicians demonstrated? The case is that of Dr. Maximilian Samuel. Here's a photograph of Samuel in his study in 1932 in Cologne, where he was a practicing obstetrician gynecologist. Samuel stood out because of the harshness of survivors' statements against him on account of his behavior in Block 10, likely in this very room. Samuel received the condemnation of many of those who worked in the infamous experimental block in the Auschwitz main camp. This preliminary impression led Robert J. Lifton to label Samuel a Jewish medical collaborator, quote unquote. However, if one digs deeper and explores another body of sources, namely accounts of women upon whom Samuel operated, one emerges with a very different impression of this man. At the crux of the matter is Samuel's coerced participation in the experiments of two SS doctors, Eduard Wirtz and Horst Schumann. The former was studying the early detection of precancerous lesions of the cervix. The latter sought to perfect a technique for rapid sterilization of large numbers of people through X-rays, and his protocol called for the eventual removal of the irradiated organs for histopathological examination to determine the extent of the damage to the tissues. While some fellow staff members in Block 10 deemed Samuel a zealous participant in both experiments, several former experimental victims praised him and considered him to be a savior. The clue that got me thinking was a witness statement by Gilda Eliezer, on whom Samuel had operated in the context of Schumann's experiment. Eliezer reported that Schumann, after performing a cursory examination of her about 3 months after Samuel's surgery, informed her, quote, "The operation of Dr. Samuel is not in order. You must have an operation by another doctor," a surgery that was carried out on November 10th, 1943. After the consultation of a variety of sources, like camp administrative documents, including pages from the Block 21 surgical register and post-war survivor testimonies, I concluded that Eliezer's case, and those of at least 4 others, in those cases, Samuel did not adhere to orders and removed the opposite organ, and thereby left in place the one that he deemed more likely to heal, and thus attempted to preserve the women's fertility. It appears that he was able to take such action because Schumann was not present at the critical moments. In the end, several women whom the Nazis had attempted to render sterile were actually able to bear children. The key is that Samuel took advantage of the additional room for maneuver when Schumann was not present, and Samuel resisted in the name of minimizing harm. The remainder of the time, however, under direct supervision, he was unable to pursue any course of action besides what the Nazi doctors ordered him to do. Samuel also attempted to minimize harm to women in the experiment conducted by Dr. Eduard Wirtz, the chief garrison physician of Auschwitz. The experiment was in the early detection of cervical cancer through the use of a relatively new device, the colposcope, which facilitates the examination of the cervix and the visualization of precancerous cellular changes. It was the invention of gynecologist Hans Hinselmann in 1925. Wirtz's experiment called for the collection of tissue from the cervix, samples that were then prepared and sent to the Altona Women's Clinic next to Hamburg, where Hinselmann would study them. Relatively few Jewish prisoner physicians encountered orders to participate in human subject experimentation. A much more common dilemma they faced was the extent to which they should participate in hospital selections through which SS medical officers and/or SS medical orderlies reduce the number of patients in inmate hospitals or clinics by sending typically the sickest and least capable of work to their deaths. The prisoner physicians had to decide what to do. One former prisoner physician points out, quote, "In our situation, normal principles of human and professional ethics broke down because the problems we had to face were previously non-existent, and in dealing with them, we did not know what to do," unquote. Their continued presence in the hospital or clinic meant that they were in a position to provide, at least in principle, some medical attention despite the absence of adequate medications and supplies. Yet such a presence was predicated upon their pleasing their Nazi overseers. To refuse the Nazis outright could lead to removal from their post, or perhaps something much more severe. In many cases, their course of action was determined by their room for maneuver at any given point. Offering some insight is the testimony of Dr. Paul Heller, a Czech Jewish doctor who trained in Prague. He was a prisoner physician at the Auschwitz subcamp of Jaworzno from mid-1943 until its evacuation in January 1945. I'd like to share a few observations from the recording. So a quote from him: "That was a very, very, very dangerous job. And I was again very lucky that my SS superior it was already towards the end of the war, and these jobs were kept by older people. So the SS man who was in charge of the hospital was an older SS man and not a passionate Nazi. So I could engineer him a little, and that made it easier, and that saved me," unquote. He said, that is Dr. Heller, said he hid a lot of people from transports, that being a very dangerous activity because, as he notes, he likely would not have survived had the head SS doctor become aware of his deeds. In hiding sick people who were likely to have been sent to Birkenau's gas chambers, Heller saved lives, but in a way that was not exactly medical. Other life-saving strategies that did not require medical know-how include hiding patients in the hospital block. So that's what we get from Dr. Heller. Pretending a patient is hospital staff, releasing and then readmitting patients, altering diagnoses, and changing names and or wards. So in some cases, we see prisoner physicians actually asking patients to pick up a broom and pretend that they are hospital staff, the cleaning staff, to avoid being selected for death. And when it comes to releasing patients, of course, that was provided that the doctors had advance warning of an upcoming selection, but they would pick patients whom they deemed at least somewhat capable of fending for themselves for at least a little while, releasing them, and then readmitting them after the danger had passed, after the selection. And when it came to altering diagnoses, in some cases, there were conditions that were known to be essentially death sentences. So one of them was typhus. So there are records of prisoner physicians changing on the inmate charts. Instead of recording the true diagnosis, they were putting something more innocuous. So the flu, for instance. And when it came to changing patients' names or transferring them to different wards, that was really to hide the fact that a patient had been there for too long. And of course, the definition of too long varied from one place to another and one time to another, sometimes from one SS doctor to another. Sometimes the limit was 2 weeks, sometimes less, sometimes more. And of course, another way to save patients from selections was to treat them. So moving away from the not necessarily medical strategies to the medical. This is one of my favorite stories. Facing a lack of medications and equipments, prisoner physicians had to demonstrate great ingenuity in their work. And here's one example of an especially clever doctor. Dr. Otto Heller, and this is not Dr. Heller, I can't seem to find a picture of him. This is Dr. Gottfried Bloch, who tells the story. Dr. Heller was the head of the hospital in the so-called Czech family camp of Auschwitz-Birkenau. He was confronted with a burgeoning epidemic of diphtheria that had already claimed several lives, but he had nothing on hand with which to treat patients. Heller reasoned that the antibodies present in the blood of those who had survived the infection could help spur the immune system in patients who were in the early stages of the illness. Gottfried Bloch, a medical colleague at the hospital, recalls Heller's actions. 25 cc's of blood of a convalescent patient were taken in a syringe flashed with citrate to avoid coagulation and given intramuscularly to a new patient as soon as he was diagnosed as having the disease. It worked. We did not lose one more patient from diphtheria. Siegfried Halbreich provides another example of how prisoner physicians were able to get treatments for patients. He describes how the medical staff of the prisoner hospital in Auschwitz III Monowitz, also known as Buna, received a package of pills from time to time from the SS sergeant who was the head of the hospital. In some cases, they worked up the courage to ask him for more. And as with Dr. Paul Heller's engineering, quote unquote, of his SS superior, the room for maneuver was defined by the character of an individual SS man. Receiving a particular number of pills presents one of the ethical dilemmas that prisoner physicians encountered: the allocation of limited medications. Others include deciding who receives care, the extent of participation in selections and experiments, deciding whether to identify patients with dangerously contagious illnesses when such a diagnosis condemned those patients to death, or whether to falsify medical information, performing abortions and killing newborns when both mother and fetus or baby would be killed, and killing patients when individual patients posed a threat to the survival of a whole barrack. Accepted medical ethical principles only just begin to offer guidance for a few of these matters. Of course, ethicists could have never imagined the dilemmas doctors would face within the extreme circumstances within Nazi camps. In medical practice, there are accepted norms regarding the conduct of triage, as in which patients are to receive medical attention first. One ethical norm aided prisoner physicians in their decision about whether to perform abortions. In medical training, doctors are instructed to save the life of the mother when both her life and the welfare of her fetus are in danger. Prisoner physicians saw the death sentence for the mother and baby as akin to a health crisis that threatened the mother, and they subsequently opted to save the life of the mother by performing abortions or infanticide. So that's a look at prisoner physicians, especially Jewish prisoner physicians. I hope this is a starting point for a much larger conversation. And thank you so much for your attention.